Hi there, I'm Rob Walker, the Regional EMS Education Specialist from the Emergency Health Services Federation, and today's presentation is all about patient refusals. Now, before we get too deep into this, let me remind you that I am not an attorney, and any information that's given during this presentation is only general information and doesn't give you any legal advice or opinions. If you have questions about the legality of your agency's refusal policies, talk to your agency's leadership or an attorney that you've got on retainer, because you do have an attorney on retainer, right? All right. The objectives in today's program are to talk about and discover the difference between competency and capacity. We'll identify the steps that you use to conduct a decisional capacity assessment, talk about high-risk and difficult refusal situations, and then give you the tools to apply that learned information in EMS field refusals. Over the course of a shift, we process a lot of refusals. Seems like 2, 3, 4 shifts sometimes. I want to show you a video of a field refusal and pay attention to what the paramedic and the EMT do while they're on scene. Some of this will make a lot of sense as we go on.
Any other medical history you got?
Diabetes, I take stuff for neuropathy.
For neuropathy?
Yeah.
Okay. Any cardiac history or anything like that? Okay. Do you mind if we get you to sit up here on this little stool right here for a second and just kind of assess you real quick? Would that be all right?
Yeah.
All right.
Fine.
Maybe check your sugar. Would that be okay?
Yeah, that's fine.
All right.
All right, sir.
Yeah. All right. On 3. 1, 2, 3. Oh, I'm sure. How long have you been on the ground?
About 45 minutes.
Oh, you've been on the ground for a minute then.
So here's the stool.
Best way.
That's all be good.
All right. My partner's going to talk to you for a couple minutes, and I'm just going to go grab the monitor, okay?
Okay, sir. So, when you fell, you weren't feeling dizzy or anything like that when you fell,
I've
or
been feeling dizzy all morning, but
all morning?
it passed and I was fine. And then I tried to bend over to get to that.
Okay, to change your license plate.
I was bent over and my knees just get wet.
Okay. Any changes in medications or anything like that, or have you missed any medications lately?
I've missed a few because I just changed pharmacies and I'm having issues getting refills.
Okay.
So,
Do you know which ones you've missed? Like with your diabetic medications?
no,
or?
that's a diabetes.
Okay. Alright, so my partner here is going to put some of our...
You're just going to scoot it up?
my partner here is going to get some vital signs on you, just to make sure everything's good, and like you said, a blood sugar check too, just to be safe. So you said you were sitting down for about 45 minutes, but you don't think you might have lost consciousness or anything like that? Or okay.
Knowing where I was at a minute, feeling absolutely stupid.
Yeah. Consciousness.
Well, we do have to ask just a couple questions just to confirm that everything's fine, just real simple questions. So do you know what month it is?
It's January.
What year?
2019.
You're off a few.
Do you know who the president is?
Oh God, Trump.
And do you know the address of where we're at right now? All right, good. So he's gonna get your blood sugar real quick, and only one more thing I'll do right away for a check after this, and then we'll see what you want to do. If you want to stand up and see how you're feeling, or if you want to go to the hospital, or anything. All right, little poke. 1, 2, 3.
All right, just gonna hold pressure. 310.
Oh,
So your blood sugar is high, and it's also saying your blood pressure as well. So do you? I know you said diabetes and neuropathy. Do you have a hypertension as well? High blood pressure?
Yeah.
You do?
You do? Have you been taking that medication?
They don't really give me medication.
For that, no?
I don't think so.
Okay.
I take some of that on the
Alright, well, ultimately it's up to you if you want to go get checked out. I mean, your blood pressure is elevated. Your heart rate's a little elevated as well. It's at 121. And then your blood glucose is a little high as well. So it's ultimately up to you.
No, I don't really think.
Okay. You're answering all of our questions appropriately, so I think we feel comfortable with your state of mind leaving you here.
Old and fit.
Okay.
Well, sir, before we go or have you sign anything, just going to ask you a couple more things or talk to you about a couple more things. So, because you do have the high blood pressure, or showing us that you have high blood pressure and the high blood sugar, that there are risks involved if we leave, that you could, with the blood pressure in, it's considered stroke range, and that with your blood sugar it could cause some more issues such as feeling uneasy, unsteady, and headaches, and things such as that nature. So we're just wondering, again, are you sure you don't want to go to the hospital? All right. So then what my partner's going to do is he'll get our computer. I just have to put in some information here from what you told me, your past history, your vital signs and such. And then I'm going to ask you again if you want to go to the hospital. And if it's still no, then I'll show you our refusal form and explain that to you. All right, sir.
All right. I don't get to keep it.
No. Won't get to keep it.
No pain or anything else, or and not? Are
I
you
have pain in my knees all the time.
and you're not feeling dizzy anymore?
No.
Okay. And you don't happen to have a list of your medications with you, or? Oh, nice.
I travel to Florida.
Well, we very much appreciate that. There's
It helps us a lot.
Yeah, a lot of times we go into a house and there's no information whatsoever, and sometimes it's just hard to get it from people. Like a long one, HTV.
Did you get the front plate on?
No.
You want me to help you do that real quick?
I'm at the school now.
Are you sure?
I'm sure.
Okay.
We have no problem helping out with it. We're here.
I'm getting my page up and something to do.
Well, what we could do, sir, is after we get your signature, we can put ourselves back in service and listen to our radio. And if we do get a call, we can go do the call. But in the meantime, we can still help with your license plate. So that way, if something does come out, we can still respond.
At the end of the day.
Right.
And actually, since I'm putting his medications in, if you want to start it now.
Airplane. All right. You got a screwdriver?
He's got a wrench.
He's got a wrench. Right. No problem. You want to hold on to your old plates?
Yeah.
Okay, I'll put them in the truck.
Thanks.
No problem. What do you want to do with your wrench?
I will put it in the front door.
All right, I can do that.
Sorry about fogging.
All right, so we're going to ask you one more time. Are you sure you don't want to go to the hospital? All right, and you understand the risks that you're in stroke range and could develop dizziness again and could develop into something more serious? Okay, so what I have here is a refusal form for you to sign. And right here on this first page here, it's just stating right here that we any information we obtain from you, we don't share with anybody. It sticks with our computer here and to our billing department, and that we won't share any of this information. And that we asked you if you wanted to go to the hospital, and you told us no, and you understand the risk for it. Okay. So if you accept the refusal, all right. So I'm going to push accept here for you, and then right here on the screen, you can just sign. Oh, and if your finger's touching it, will pick up your finger.
It's like an accident.
3027 will be regulated to procedures on 10th place.
All right, sir. Thank you.
Is there anything else that we can do for you?
Nope.
All right. You have a wonderful rest of your day.
Sir, from you, if it's okay, can I get your name and your signature to verify as a witness that he signed our refusal form and understood all the risks?
5117, still my first birthday.
Well, before we go back in service, sir, is there anything else we can help you with? Get you inside or get anything for you? All righty, sir.
Being on the ground is a bad thing.
All right. We understand.
All right, sir. Well, there's something else we can do.
Yeah, no problem.
Take care
of yourself,
Just
okay?
putting the license.
No problem, no problem. Take care of yourself. Thank you.
And good luck with your doctor's appointment tomorrow.
A lot of things in that video were done right, and a few things could be done better. We'll talk about that when we get to some case reviews. Most of us have had a lot of practice with refusals, and most of us do a fair amount of them. In fact, somewhere between 15 to 20% of the call volume at most agencies, and in some places where it's really busy, almost 30% of the total call volume is a refusal. However, it's still fraught with problems. One of the most common sources of EMS litigation is a case where a patient refused treatment or transport. You got on scene, made some type of patient contact, and then for some reason decided not to take the patient to the hospital. Refusals are problematic. Now, when we talk about refusals, it's important to remember that competent adults, with a few exceptions, always have the right to refuse EMS assessment, treatment, or transport. That's called patient autonomy. They have the right to make decisions for their own health care. And when we document a refusal, the goal of all of that paperwork and documentation is to limit liability for the EMS agency and the providers. Now, having said that, there are a few myths about EMS refusals that we need to talk about, and we're going to get to some of those here. Myth number one, everybody needs to go to the hospital. There are a lot of places that don't do refusals. They just take everyone who calls to the hospital. You call, we haul, that's all. Now, we know that that's not an effective use of resources, and we know that everybody who calls 911 doesn't need to go to the hospital. But it's the job of the EMS providers to determine if the patient that you make contact with has the capacity to refuse transport and treatment. So we're going to talk a lot more about capacity here in a couple of minutes, but just remember, not everybody who calls 911 needs to go to the hospital. Myth number two, your patient has to be alert and oriented ×3 or ×4, whatever you use. Now, just because your patient is oriented doesn't mean that they have decision-making capacity. They may know who the president is and where they are, what day it is, and how many quarters make a dollar, but that doesn't mean they can make decisions. For example, schizophrenics often have lost touch with reality and think that you arrived on the scene in a UFO, and when you take them to Lancaster General Hospital, there's a giant brain-sucking machine there that will remove all the thoughts from their mind unless they wrap themselves up in aluminum foil. So while they may be conscious and alert and oriented, they do not have decision-making capacity. Myth number three, everyone totally understands what you're saying. Of course they do. They all watch Grey's Anatomy. They all speak medical lingo. Well, that one's not true either. And in fact, most Americans have a hard time understanding what medical professionals tell them. It's called medical literacy, and it's very low in most parts of the United States. PA people just don't understand what we tell them. So when we're explaining risks and consequences, we have to do it in a language that's easy to understand. Sometimes we may need to use a translator to make it understandable for them. You also can't use those, I'm going to be okay, everything's fine, I understand. That does not mean they understand. A lot of that is deflection. So make sure when you're explaining what's going on to your patient, they're able to explain it back to you in their own words. And myth number 4 is the big one. Telling your patient, if you don't come with me to the emergency department, you might die, is not enough. You actually have to give your patient a differential diagnosis and explain consequences of that differential diagnosis to them. So if they're having chest pain that you believe might be an MI, you have to explain to them the consequences of not being treated for that. All right. So don't just kind of give them the old, you're going to die if you don't come with me. Actually give them concrete reasons why they need to be seen at the emergency department. Let's talk about competence versus capacity. When you call medical command and try to get a refusal, the doc may ask you, is your patient competent? Well, maybe, maybe not, because competence is a legal definition. It's a legal term. Courts determine competency. That means that a person can make their own decisions legally. Capacity is what we're concerned about when we're looking for medical decision making. This is the patient's ability to understand and process and make decisions based on what you're telling them. So they have to understand the risks, they have to understand the burden and the benefits and alternative to what you're trying to explain. And then you need to be able to understand that they understand that. Okay, that is decision-making capacity. When we look at determining decision-making capacity, there are several steps that we need to follow. And if we look at the long, in-depth process, there's 10 or 12 steps we need to follow, but we've kind of distilled it down for EMS. And there's 4 big ones. The patient has to be able to understand that they need to make a decision. They have to understand the risks and consequences that come with the decision that they make. They have to be able to communicate those risks back to you, and they can't be coerced to make a decision. That means family members can't withhold food or money. Police officers can't threaten with arrest. They have to be able to make this decision on their own free will. Again, patient autonomy. They have to be able to make the decision on their own. There are a couple of ways we document the capacity assessment. There's a couple of different mnemonics out there, but this is the one I like best when we talk about documenting refusals. It's called FEARS. And when we're documenting refusals, there's a couple of things that have to happen. You have to document that your duty to act was fulfilled when you responded to the call and made patient contact. You have to prove the patient's capacity and competence, and you have to demonstrate that they made an informed consent and decision. And the FEARS acronym or mnemonic for documentation of a refusal is a great way to do it. And here is the FEARS mnemonic. F is a full exam with a set of vitals. And ALS providers, yeah, that's a 12-lead ECG. You have to explain the real risks to the patient. And by that, I mean, ma'am, I believe that the pain you have in your chest might be a heart attack, and you need to go to the emergency department with me so they can take care of that. They can do a better assessment. You need to come with me, because if you don't and I leave you here, you could get worse and die from this MI. Explain what's really happening and use real words. Also, include your limitations in there. Ma'am, I know that I can see a lot of things with my cardiac monitor, but I can't tell if you're having a heart attack or not. That needs an assessment at the emergency department and some blood work. Right? Ask for assistance. Get the family to help you if your patient needs to go. Have a supervisor come and help. Get the medical command doc on the phone. The R in FEARS is for recording the entire discussion. And I don't mean make a video recording. What I mean is write down everything that happens. Every discussion you have with the patient should be in the narrative for refusals. This is where you need to take time and paint a good picture as to what happened. And then the S is for a supportive attitude. You need to be understanding. If your patient doesn't want to go to the hospital, it's not your fault. They might be scared or nervous, but you need to be supportive. Try to convince them and try to calm their fears. If we look at patient refusals, they really fall into 3 different categories. And I like to break them down into the I don't think I need to go, the nope, I'm not going to go, and someone else said no. And here's how this kind of looks. I don't think I need to go. This is like a lift assist. Nope, not going to go. These are the difficult refusals. And someone else said no. This is when you're about to make patient contact, or you make patient contact and somebody says, I don't think they need to go, and they kind of get in the way. So we'll talk about these 3 scenarios and how you handle processing refusals for all 3. So here's number 1. This is the I don't think so. And we go on these all the time. In fact, I went back and looked at the ESO archives for lift assists and class 3 falls and found hundreds of them across the region. This is a really common call. When you get dispatched on this call, it's a class 3, 68-year-old female, fell out of bed, says she's not injured, she's alert and breathing, and just needs help up. Now, do you need to do a refusal for this? Well, yeah, and here's why. Middlesex London EMS, it's paramedic service in Ontario, is a pretty busy service. And they did a study back in 2013. They went on just over 42,000 calls for service. That's a few. Out of those 42,000 calls, 804, a little over 1% of them, were for a lift assist. And they actually have, or did have, a disposition in their EPCR software for a lift assist. And they defined it as an individual who's assisted up from the ground by paramedics, but not treated or brought to the hospital for further medical attention. Interestingly enough, they no longer have that disposition in their EPCR, and they use that patient refusal disposition. And here's why. From those calls in 2013, they went back and did a retrospective study in 2017 and looked at those lift assist calls and found within 14 days of the 911 dispatch for a lift assist, out of those 804 patients, 169 of them wound up going to the emergency room anyway. Out of that, 93 of those patients were admitted to the emergency room. And out of those, 9 of them died. So, in looking at these reports, they realized that there were some big problems. One, full assessments weren't being charted. They were missing vital signs, they were missing blood glucose, they were missing 12-lead ECGs, and they realized that 21% of those patients needed to be in the emergency department, and they recognized that lift assists, a simple pick someone up off the floor, is an early indicator of problems requiring medical evaluation. Now, I am not saying that every patient that you pick up off the floor needs to go to the emergency department. That is not the case at all. Refusals can be appropriate in that case, and they recognized as well in this study that even if they had done full assessments, many of those patients still might have refused care, treatment, evaluation. But you have to remember that the refusal paperwork is designed to limit liability. So a refusal may be appropriate, but you have to document it correctly. You have to do a complete assessment. You have to see if your patient can walk. See if they're able to walk from the chair back to their bed. See if they need some additional services. This is a great opportunity for you to become a patient advocate and involve Office of the Aging or social services. Maybe call a family member and say, hey, mom can't take care of herself. She's on the floor and she really could use some help. When you write this refusal, document a complete set of vital signs and an assessment of the patient's capacity to refuse care. These are the hallmarks of a good patient narrative for a refusal. And I actually found one that was a recent refusal from the last few months, and I looked at it and it was just perfect because it had all the high points that we want to see in a patient refusal PCR. This is a great one because it says the patient was assisted from the floor to a standing position by providers with an extremity lift and was able to walk to the bed without assistance. Great, this patient's able to ambulate. After being assessed by EMS with a full assessment documented above, and yes, I did look, all the vital signs were there. There was a blood sugar done. There was a stroke assessment done. The patient stated she doesn't think she needs to go to the hospital. EMS explained that they're not physicians and cannot perform a comprehensive assessment. They educated her on the limitations of their assessment. The risks of refusing treatment were explained, listed here in layman's terms. They made it easy to understand, including but not limited to other falls, injury, illness, and death. The patient stated that she understood the risks, repeated them back to the EMS provider, and still wished to refuse care. The patient was advised to call 911 if she falls again or condition worsens. She was offered transport to the hospital 3 times. She denied the need for transport clearly each time. She then signed and dated the refusal form, which was witnessed by a police officer who signed the witness box electronically. This is a great patient refusal because it hits all the points of a capacity assessment and details the efforts made by the EMS provider to attempt to take the patient to the hospital. She said no. They asked again. She said she understands. She still said no. They documented all of these asks and all of her responses, and it looks like a very appropriate refusal. Now, when we look at more high-risk refusals, this is refusal scenario number 2. And I call this the no way, I'm not going to go refusal. And these are the ones that keep me awake at night. No way, I'm not going to go. Here's what happens. You're dispatched for class 1 chest pain, 67-year-old male with chest pain. He's short of breath, sweaty, and vomiting. He has a cardiac history. This is a no-brainer. This is an ALS call. This guy does not look happy to see you. You walk in, hey, how you doing? I'm Rob with the ambulance. Guy looks angry, and as you start to ask some questions, he looks up and says, listen, buddy, I am not going to the hospital with you. Ain't happening. You might as well just leave right now. So now we're in this spot where we've already kind of got this adversarial relationship going on. What do? Well, you try your best to convince him to go to the hospital. These are the most difficult refusals to process. These are high-risk refusals. These are the ones where the patient has a real emergency, needs to be seen in the emergency department, and doesn't want to go. You have got to do your best to get this patient to the hospital. And this is where you want to call in the cavalry. Get some help on this thing. Great thing to do. Family members. Family members can often provide enough guilt that your patient will agree to go to the hospital just so they stop bugging him. I use, pictures on the mantelpiece. I ask about the kids. I ask about the wife. What would your daughter say if she was here? She would want you to go to the hospital. She would be worried about you. Guilt trips are cheap. And if your patient really needs to go, you can use that stuff. Get the doc on the phone. There was a recent study that showed medical direction on the telephone, speaking with the patient, improves the chances of the patient agreeing to be transported. Get the doc on the phone. Sometimes that voice of authority is what they need to hear. Absolutely use the medical command physician for this. Or use your fire and police colleagues. Use the people that you came with. Maybe a fresh set of eyes see something that you don't. Maybe you're starting to get frustrated and your partner is not. Maybe the police officer that's there can say, listen, you really need to go. You can use what you have with you for resources. Now, you have to remember, some people will make decisions that we don't agree with, and patients are allowed to make those decisions if they have the capacity to make that decision. We don't agree with it. We don't love it. But yes, patients can make the decision to stay at home. It's not you. It's not your fault. It's not your emergency. Sick people can be irrational, and that's okay. But you got to give it your best shot. But don't be a jerk, because who gets sued? Jerks, right? Incompetent people and jerks. So try to be nice, as kind as you can. If you need to walk away for a moment and let your partner talk to him because you're getting frustrated, do it. It's not you. If it ends up in a refusal, despite your very best efforts to get that patient to the hospital, you've got to be sure to document the fundamentals of this patient interaction very well. All the signs and symptoms, mental status, capacity, vitals, your clinical impression, and a narrative detailing the specific risks and why the patient refused. Have them sign the refusal, and then have a witness that observed all of the process sign as well. This is where police officers are great. Okay, you've got to get that thing signed. It's a legal document. All right, let's look at refusal scenario number 3. This is someone else said no. And we go on these calls all the time as well. And this one is a little sticky. And I want to spend a couple of minutes talking about this, because this is a Class 2 motor vehicle accident, 2 vehicles in a parking lot. You're unsure if there's injuries, there's lots of yelling, and bystanders say an airbag is deployed. We go on these all the time, right? Walmart parking lot, thud, 2 cars hit. You pull in a parking lot, you see a couple of banged up cars, one with a deployed airbag. There's 2 adults standing outside, exchanging insurance info, and a police car is parked next to the crash. As you get out of the ambulance and start to walk towards the people exchanging insurance info, cop jumps out of his car and says, "Hey, I asked here and nobody needs EMS. You can take off." Can you just get on your radio and mark yourself available? Some people say yes, other people say no. And I'm going to tell you, in my opinion, and the opinion of just about every attorney out there, in this case, it's safer to obtain a refusal. And here's why.
When I was in a wreck, it felt like my life was shattered into 1,000 pieces. So I called a hammer.
The Nashville law firm got $1 million settlement for our client who was hit by a tow truck.
If a reckless driver hits you, it's not your fault. You deserve to have your medical bills and pain and suffering paid in full.
When hurt in a car accident that wasn't your fault, you should call Daggett Schuler first, before you call the insurance company.
Car accidents, they're scary, violent, unexpected.
They don't call them ambulance chasers for nothing. Not every accident ends up in court, but good documentation can make the difference. And I'll give you an example. You arrive on the scene of a motor vehicle accident. You see the patient sitting in his car. It's not a patient at that point. It's just a guy sitting in his car. He sees you. You make eye contact. You start walking that way. The cop says, "Hey, I just checked with everybody. Nobody here needs any EMS. You guys can go available." You say, "Cool." You turn around, you get back in your ambulance, and you mark up with county and say, "No EMS required, canceled by law enforcement." This guy driving his car develops some neck pain. A week or 2 later, goes to the chiropractor, goes to an attorney because insurance is denying the claim for the medical. And the attorney says, "Well, let me get the ambulance report." And the guy says, "Well, the ambulance people never even talked to me. I saw them pull up and then they turned around and left." Okay, so this is a problem now, right? We want to have documentation that says you talked to this guy. And it can be as simple as approach driver of vehicle 1, a red Toyota. He responded that he didn't want to provide his name or any information and didn't require any EMS evaluation or transport. Returned to his car and closed the door. Refused to sign a refusal form. You've got some documentation that you made contact with this guy, that you didn't just ignore him and abandon him on scene. So it's worth getting a refusal. There are enough personal injury lawyers out there that make their living on these cases. You do not want to get caught up in that machine. The written record matters. Even if you say to the guy, do you want to go to the hospital? He says, no. Great. Document that stuff, because 55% of people surveyed after a refusal say they recalled getting written instructions. Only 22% remembered any explanation of the risk of refusal, and 26% say they didn't fully understand their condition or circumstances. So a large number of the patients that are refusing care or evaluation or transport have no idea what's going on and remembered what you told them. So it's very easy for a patient to see an attorney and say, the guy told me I didn't need to go to the hospital, that everything was going to be fine, and now I've got a fractured C4. Absolutely not. If you pull out your documentation with a well-written refusal that shows that the patient said his neck was a little sore, but he didn't want to go to the hospital and refused any treatment or transport, now you've got documentation of that that's signed. And it's much easier. And it's much easier to be able to defend a well-written refusal than it is to defend a no patient found or a no contact after you've been on scene and marked there in the CAD. So remember, document everything. Show that you fulfilled your duty to act, prove the patient's capacity and competence, and demonstrate their informed consent for the refusal. Use the FEARS mnemonic. Get a full assessment with vitals for every refusal. Explain the real risks and consequences and the limitations of your exam to the patient. Tell them in clear, easy to understand words what the consequences are. If you feel that they need to go, get some assistance. Call a family member, call a supervisor, get the medical command doc on the phone, and document everything that happens. Write a clear, precise narrative. And then be nice about the whole thing. If they're refusing, say you understand, be kind and supportive. Don't get mad about it. Don't be a jerk. So to sum up this piece, EMS providers need to assess decision-making capacity when obtaining a refusal. Conscious, alert, and oriented ×3 or ×4 just doesn't cut it. They have to have decision-making capacity. You have to do a full assessment in vital signs, even on simple calls like a lift assist. Clear and precise documentation can save you and reduce liability for you and for the EMS agency. And the big takeaway from this whole thing is, if you ever get on scene, talk to a patient and think to yourself, should I get a refusal for this? Get a refusal. It doesn't take much time to write a clear and precise narrative when you explain the risks, get a set of vital signs, and the patient refuses. It's okay, but you do have to write a complete narrative with that refusal. All right, thanks for spending some time with me here talking about patient refusals. I hope you took something away from this. If I can answer any questions about the refusal process, or you just have something else that you want to chat about, my email address is here, rwalker@ehsf.org. And thanks for watching.